This episode of the Jerry Paul Podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Paul Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, today we're going to be talking about potentially unsafe, low evidence therapies, how we address that with our patients. But before we do, who's with us today?
We are delighted to have three guests from my undergraduate alma mater, the University of Michigan. First up, we have Adam Marks, who is a med peds and palliative care physician and associate professor at the University of Michigan. Adam, welcome to the Jerry Pal Podcast.
Thanks for having me.
And we're delighted to welcome Laura Taylor, who is also med peds and a palliative care doc and assistant professor at the University of Michigan. Laura, welcome to the Jerry Pal Podcast.
Thank you.
And we're delighted to welcome Jill Schneiderhan, who is a family medicine and integrative medicine doc and associate professor at the University of Michigan. Jill, welcome to Jerry Pal.
Great to be here.
So we're going to be talking about a paper that was published. Oh, Adam, what journal was it published in again?
American Journal of Palliative Medicine.
And we'll have a link to it on potentially unsafe low evidence therapies and approach to dealing with that. But before we jump into that topic, Adam, I think you have a song request for Alex.
Yeah, I'd love to hear Bad Medicine by Bon Jovi.
Very apropos. Why did you choose this song?
Well, I think this topic has to do with sometimes the decisions our patients make that can be confusing and maybe even upsetting for us as clinicians. And so this seemed a very appropriate song.
Great. Alex, get it away.
Right. Ain't got a fever, got a permanent disease. It'll take more than a doctor to prescribe a remedy. I got lots of money, but it isn't what I need. Gonna take more than a shot to get this poison out of me. I got all the symptoms, count them, 1, 2, 3. That's what you get for falling in love. You get a little, but it's never enough. On your knees for falling in love. And now this boy's addicted cause your kiss is a drug. Your love is like bad medicine. Bad medicine is what I need. Shake it up just like bad medicine. Ain't no doctor that can cure my disease.
Wonderful, Alex.
Amazing.
Alex loved that song, I could tell.
I did love that song.
All right.
Yeah, that's a lot of fun.
So we're going to be talking about potentially unsafe, low evidence therapies. And you created an acronym for this. Is it French? PULET? Alex, how would you say that in French?
PULET.
PULET.
Zut alors, poulet.
What is it poulet or what is this?
We do the hard T here in the Midwest. And so for us, it's pullet. But
Pullet, like a mullet.
Interpretation. You got it.
And what is a pullet?
Well, just as it says, it's a therapy that it has little to no evidence and we believe poses a significant risk of harm to the patient that's pursuing it. And so this term was developed by our group to capture either non-traditional therapies or really conventional medical therapies that patients may be pursuing with little hope of reaching a goal of care and significant risk.
And Jill, you practice complementary alternative and integrated medicine. Did I say that correctly? Is it
You just threw all the terms together.
I am now.
So actually, we prefer just integrative medicine now because we're trying to really combine things into one medical system. So we've kind of let complementary alternative go by the wayside.
So I guess from your perspective, how often does this come up when we're thinking about these PULETs, potentially unsafe, low evidence therapies in the work that you do?
Yeah, I think it's actually really interesting because when Adam first brought this to me, I was like, oh, there's so much of what we do that actually has more evidence than we think it does. And I think sometimes the bias is none of these things have evidence. But the truth is, and especially more recently, I'd say in the integrative space, people are coming in asking us about things that are much more on the unsafe, no evidence side, much more often. I'm having these conversations every single day.
Can you give me an example? So what are some of the frequent ones that are coming up?
Recently, actually, ivermectin in cancer therapy is coming up regularly. I would say off-label use of drugs is much more commonly coming up in my space. Ivermectin was also coming up a lot during the COVID conversation, patients asking for me to prescribe it in advance. But there's a lot of other things too. Patients want to pursue expensive. I'd say chelation therapy is probably another one that comes up a lot in my space.
Stem cell?
I hear that one a lot less. I don't know, maybe that comes up more on the palliative side, but in the integrative space, a lot less.
Yeah, we've heard it.
Yeah. Laura, you were going to say something too?
Oh, yeah. I was just going to mention that I think these potentially unsafe low evidence therapies can really cross a broad spectrum of potential interventions, including really extreme interventions like traveling to Mexico for high dose intrathecal stem cell injections. This was actually a case that I encountered recently where a patient with a spinal cord injury traveled to Mexico for stem cell therapy, injected into the spinal fluid, and he developed a really rare mycobacterial infection, which was incredibly difficult to treat, ended up causing even more harm, even more functional debility than he already had secondary to a spinal cord injury. So a pullet could include something like that. That's very expensive, requires travel, things that Jill is mentioning. Also, I think we conceived of pullets as potentially encompassing therapies that might be floated or recommended by some of our colleagues, but that have potential harms or potential risk with low likelihood of benefit. So included in there would be things like chemotherapy in the last 2 weeks of life, right? Could be considered a pullet, potentially unsafe, potentially inducing harm with low evidence of benefit. So we wanted the definition to be pretty broad of what a pullet could be.
CPR in an individual with metastatic cancer in the ICU?
Mm-hmm. That could be a pullet.
Absolutely. I think we were very conscious of not wanting this to be sort of, traditional medical interventions versus others, right? Because I think as Jill said before, sometimes our bias makes us think there's no evidence for any of it. But in fact, we've seen a lot of patients engage in therapies that we think are a bad idea with a high risk and low benefit.
Yeah. And so then maybe it'd be helpful to talk about what is not a pullet. Pullet. Yeah.
Alex wants to do the French.
I'm trying to decide what is
poulet.
Poulet.
We can change it to poulet. It sounds cooler.
It does sound cooler.
It's always better with a French accent. It rhymes with mullet. I had a mullet when I lived in Michigan in high school. So I kind of like that it rhymes with mullet. That's from Michigan.
Alex, you had a mullet.
I had a mullet. Yeah.
Can we share that online on the Geriatrics listeners?
There's no documented photographic evidence that I have.
I think there probably is. Alex's mom, if you're listening, send me that mullet picture.
Oh no.
I
was going to ask, what's not a pullet? Can we say some things that aren't?
I would name acupuncture for a host of different conditions, but I still have people tell me there's no evidence for it. I would say there's a fair number of herbs and supplements that probably fall in that category that people say, oh, there's no evidence. Actually, there is some, and some of them are very safe. And so I think there are some things that cross that boundary that way.
I think the most common complementary alternative medicine out there for cancer patients, which I think 60 to 70% cancer patients take some type of thing, is like a multivitamin. And vitamins in general. Would that fall into a pullet or not?
I don't think so.
I don't think so either. I'm thinking of some of the high dose water soluble vitamins that people get in intravenous infusions. I think they may not be likely to provide much benefit, but because they're water soluble and you just pee it out, they're probably not causing much harm except for potentially financial harm if they're very costly. But I'm not sure that those would be considered pullets just because the likelihood of frank harm is pretty low.
Okay. Another question. Steve Jobs, he decided not to get chemotherapy or Western medical therapy for his pancreatic cancer, which was a very treatable pancreatic cancer. Instead, he did herbals, I think like a vegan macrobiotic diet. So by itself, those had very little risk associated with them. The only risk was delayed treatment for his cancer. Would that fall into a PULET?
For me, I would say, he's more foregoing a treatment than engaging in something that I think is unsafe. When we talk about the ways that we approach patients who are engaging in this, I think a lot of the principles will be the same. I don't want to jump the gun, but I wouldn't call his decision a potentially unsafe, low evidence therapy. Because like as you said, the things he was deciding to do were themselves low risk. It's just that he was foregoing things that we think would have provided him more benefit. I don't know if my co-authors would agree with that.
Yeah, I was just, go ahead, Jill.
Oh, I was just going to say, we treat people a lot where we combine, like we do adjunct, supportive care with all of the things on the list of things he tried. And doing those in addition to cancer treatment would have been totally reasonable. He just left the actual cancer treatment off. And so I think it's, again, just like Adam said, more about what he didn't do than what he did do.
Great.
Mm-hmm. And I think I would categorize his behavior as perhaps engaging in some science denialism, right? So rejecting sort of conventional medical therapies with a strong, large body of evidence for benefit and engaging in low evidence therapies, perhaps promoted by folks who are not experts in the field with very low evidence of benefit. So that's sort of a different type of behavior, but the treatment itself that he engaged in probably, like everyone is saying, wouldn't be considered a PULET per se.
And let me ask you this. I'm going to go back to the nidus of this. Why did you even decide to write this article? Adam, I'm going to start with you.
Yeah, thanks. I think my approach to, writing papers is really kind of the patient cases that stick with me. And this is one of those examples. Years and years ago, the first few years as an attending physician, I was consulted to take care of a gentleman with metastatic esophageal cancer. And he was admitted with hemoptysis. And as I was getting ready to see him, I saw that a month before, his oncologist had said, we don't have any more disease-specific treatment, and I recommend hospice. And the note reflects a very angry response. I can't believe you'd give up on me. I'm going to beat this thing. And that was the last time, that he'd been seen by our healthcare system. As I was talking to the team that had admitted him, they shared with me that he was engaging in what I'll call an alternative therapy that was argon light therapy. And so this was someone that would come to his house and they would draw a sample of blood and they would take it to their argon treatment facility and they would run it through their machine and they would bring it back, and you wouldn't believe it, but the blood had turned clear, and they would inject it back into him to treat his cancer for the low cost of $400 a treatment for this weekly treatment. And the cancer team that had been consulted in the hospital told him this is nonsense. And of course, they were thrown out of the room, right? And so immediately I knew two things, or I'm not going to bring up hospice with this guy, right, at the first bat. And I'm also not at the first bat going to challenge this intervention. And I can't, I was working with my interprofessional team, and they did a much better job than I think I would have had been on my own of tell us more. How did you learn about this? What is this supposed to do? What do you hope? How will you know it's working? Sort of thing. Is there anything that you're worried about with it? And we were able to engage in a conversation about providing him the best care possible while he continues to engage in this therapy, right? That could include a robust home care plan to manage his symptoms. And that's how it could have segued into this hospice conversation. So it didn't have to be hospice or this treatment that you're pursuing. At the same time, we try to learn a lot about the person who is prescribing this medication because we are worried about harm and fraud. And so this, it came up, we were nicely able to align with the patient, learn about his goals and values, and it came to a good conclusion. But it really made me think about, how we approach patients who are engaging in those things that not only do we not think they're helpful, but this is actually harming you. But I have to be careful how I present you with this because, you've already sort of dug into a worldview that isn't going to accept necessarily my opinion.
Yeah.
Could I just jump off?
Please,
of
Laura.
Adam shared. when Adam introduced the idea of this paper to me, I came to it from the standpoint of a clinician who's really interested in serious illness communication training. I direct our Powered by Vital Talk program here at the University of Michigan. I'm a big Vital Talk apologist, and I really like the idea that we can create communication tools and roadmaps to be able to teach our fellow clinicians how to effectively have these tough conversations with patients. And it really is tough when a patient comes to you with a lot of skepticism about the therapies that you have to offer and what you have to recommend. And they're wanting to pursue these treatments that, as Adam said, may in fact be harmful, and it may prevent them from engaging in some of the other recommendations that we think would really make a difference and would really help. So I came to this from the perspective of wanting to really think deeply about how to lead these conversations with an empathic approach. And I think for many of these patients, the seeking of these alternative therapies that may potentially be harmful is often a manifestation of some underlying distress or an unmet need, of concern about feeling abandoned by conventional medicine, especially for those who have a serious illness for which there are not many good options to ameliorate the disease, to prevent progression, to extend their life. So I just was seeing a lot of distress in these patients who are pursuing some of these interventions. And I just wanted to think really hard about how we as clinicians could approach it with empathy and humility.
Yeah, that's great. And I just have to highlight before we move on and hear what Jill has to say about this, that Laura self-identified as a Vital Talk apologist. Why
It's
did you
true.
What is apology? Why did you say that?
I find that being able to teach fellow clinicians some very practical techniques for how to have serious illness conversations skillfully has really helped me refine my skills, but also I think helps my colleagues who go into some of these conversations feeling really stressed and distressed and worried that they're not going to go well. I think sometimes these patients are labeled as difficult when really what they are is distressed and they're experiencing strong emotions. And so I think identifying some tools to be able to approach them with the humanity and empathy that they deserve is very gratifying for me. And I think the Vital Talk tools, I think the remap framework for conducting a goals of care conversation can be really translated and applied to being able to understand patients' values and priorities surrounding the pursuit of PULET, PULET therapies. So I just find it a very useful analogy.
Jill, you live on an interesting intersection, right, in integrative medicine. How did you think about this when you're together thinking about writing this article?
Yeah, I thought it was, when Adam introduced it to me, my initial reaction was like, oh, they're going to write about how bad all these things are. And, how do I really bring the voice of integrative medicine into the conversation? So I think that's where my initial thoughts were. And then as I'm listening now, also, I think the other thing that's just very different in the space I work in is that I'm not always in the space of the high emotion content patient, where, the patient population I work with runs this huge gamut from just my average primary care patient who wants to improve their life and prevent illness through integrative modalities, all the way to the patient that's battling serious illness and wants to use these range of therapies. And so I think I just have this long gamut or a long range of using this conversational techniques, discussing these therapies in a lot of different settings.
And two of you are med peds, and Jill's family medicine, so you have the potential to work with kids too. Is this different when it's the parents arguing for this treatment for their child?
Laura and Jill, I'd be interested to hear your perspective, but I'll say I think the themes are similar. I think the emotion is amplified when we're talking to parents of especially seriously ill children.
Yeah.
And I've had a couple of cases similarly where parents are pursuing treatments that not only do I think that they don't make a lot of physiologic sense, but I'm deeply concerned about. And in addition to my work in palliative care, I also am a clinical ethicist, and the ethics change there, right? So obviously, if you're an adult, you have the ability to do whatever you want to do. There's not much I can do about that. For children, it's very different. if I have reason to believe a parent is going to engage in a therapy that poses a harm to a child, then I'm called upon to intervene there. So the ethics is a little different, but my clinical experience is just the emotion is much higher in these instances.
I agree with what Adam said. And I think we prioritize personal autonomy in Western medicine. And so an adult patient who has the medical capacity to choose to pursue a potentially unsafe low evidence therapy, I'm going to, of course, allow them to do so after a thoughtful conversation about the potential harms. But it's completely different, right? When we're speaking with a parent of a minor child who does not necessarily have the ability to say no or to decline that treatment. And so we definitely prioritize non-maleficence in that situation where our top priority is to do no harm to that child. And so, we might find ourselves as clinicians in a situation where we're needing to report that parent to Child Protective Services. And of course, that's an extremely adversarial situation that we never want to end up in. And so I think these communication techniques that we talk about in our paper are that much more essential to master and to be able to use when you're speaking with a distressed parent.
Well, let's start off with that. So I'm going to present a case. This is a daughter of a patient with widely metastatic cancer, very poor functional status, mets to the lung, has brain mets that's making them confused. So we don't think that they have capacity. I'm going to throw some of the pediatric stuff. Now we're dealing with a surrogate decision maker. The daughter was listening to Joe Rogan in January where Mel Gibson was on, and Mel Gibson said he had this friend who took ivermectin, and that's all that they took, and their cancer disappeared. They hear from the oncologist that there are no more cancer-directed therapies. Daughter comes to you and says, "You're telling me there's nothing else. I see that ivermectin is a treatment. Joe Rogan's show said so. I did some research."
That's a competing podcast for people who are listening. We generally do better than Joe Rogan.
I think we do better.
Yeah.
Can you prescribe him some ivermectin for his cancer? Because I don't want him to die. And you're not doing anything else for him.
Yeah.
Anything else you want to turn up the volume on that, Alex? Does that sound pretty good?
That's pretty good. Yeah.
First, as the clinician, I would take a deep breath and check my own pulse. Because
I'm already running out the door at this point. I think that's a better response than me.
I mean, I'm hearing that feels very real to me. I don't know, Jill, and I mean, that feels like something that we could encounter. That feels really real. And I think gosh, my first step there is to acknowledge the distress that family member must be feeling on behalf of their loved one, right? This is an absolutely horrible situation. And so use those skills of verbal empathic responses that we all know as clinicians, right? It must be devastating to hear that news from your oncologist that we don't have any further treatments directed to be able to treat your advanced cancer. That is awful. And let that sit in the room. I think before we do anything, we have to show them that we empathize with the really difficult position they're in. So that's for me, that's step 1, 2, and 3. And unpacking that emotion it might take a little bit.
So not jumping straight into the cognitive answer. Ivermectin doesn't work.
Never, Eric.
How dare you bring something like that into my office? Get out. No, you're not going to do that. You're going to address emotion first.
The response of "that's dumb and you're dumb for wanting it" is not the appropriate response. I would absolutely empathize, and I would go on to even validate and say, right, I see how hard you're working for your dad, right? Because you're hearing from your cancer doctor that we have nothing left to offer to treat his cancer. And I'm hearing you say that can't possibly be true. I love my father. I can't lose him. There must be something.
Yeah.
And I think that makes a lot of sense. I would feel the same way. So, I mean, and we talk about this with a lot of kind of conflict, and you can conceptualize this as a conflict, but underneath the strong statements from the family members is a deep love, right? And I'm always reminded of that quote that the opposite of hate isn't love, or the opposite of love isn't hate, it's indifference. And when family members are coming at you hot about anything, it is always because they deeply, deeply love this person that they are caring for. And so I recognize that and I acknowledge it, because chances are, if they're coming to you for this, like ivermectin, please, someone else has told them it's dumb, right? Family members, another doctor. So they've already been rejected. They've already said it's a dumb thing and you're dumb for wanting it. And so I find that when I validate that, oh my gosh, what a loving daughter you are. Your father is lucky to have you. I can see how hard you're fighting. Like that brings down the temperature in the room, and you can begin then the work of aligning yourself with that person. What are we hoping the ivermectin is going to do? What are we hoping for however long your father has left to live? What are we hoping that looks like? Let's talk about that. I want that same thing.
Yeah.
But Jill, I know I think this is a theoretical conversation for us, at least with the ivermectin. I know this is a very real conversation that you had with people.
Yeah, I was thinking not to the same intensity, though. I think the intensity's ratcheted up from what I deal with most of the time in my offices. But what I'm thinking, too, is once I do all those things you guys are talking about, the next thing I'm going to do is really understand if anyone has done a study on ivermectin in cancer. I think the answer is no. One of my integrative oncologists just looked this up recently, but I'm going to do a little bit of PubMed searching, and I'm going to just get a sense of if there's one RCT with 20 people or nothing.
So are you doing like a pause? Do you have them come back? Because like at this point, like what's happened to me in these scenarios, like, I don't know. I've heard a lot about ivermectin and COVID. Like we have pretty good evidence that it doesn't work there. I don't know about cancer. How are you fitting that into the conversation?
Yeah, it depends on the setting. So some of these, if I'm doing a full consult and someone's bringing that up and it's a topic I have never dug into before, I'm probably pausing. Again, usually mine's not like deathbed, give it to me now. Yeah. Mine's usually like, hey, can we talk about this? And I can bring them back in a little bit to let them know that I did some research and here's what I found. So having like a secondary conversation after the first conversation, I have done PubMed searches right in the room with a patient, say, hey, let's look this up together. Let's see together what evidence there is. Like, oh, there's one really small RCT. If there's stuff there, then I might say, hey, give me a chance to digest this stuff through my medical lens and then come back and let's talk about it versus, look, nothing's here. Let's try a couple more search terms. And together we realize like, gosh, from a Western science, like perspective, this actually hasn't been looked at. Like, I can't tell you if this is going to, help or hurt.
And go ahead, Laura.
The risk factors.
Oh, I was just going to add that I think in addition to sort of doing our homework as clinicians, like Jill mentioned, I think one of the things we really emphasize in our article is really taking on the role of a student, right? Like, maybe it's not ivermectin, but maybe it's some other medicine or intervention that we're just completely unfamiliar with or that hasn't been researched at all by Western practitioners. And so I'm going to go into my humble inquiring student mode, right? Like, tell me what you know about ivermectin for cancer therapy. Tell me where you learned about this. Do you know other friends or family members who've used this therapy? What have they used it for? What have they learned about it? What results did they get from it? And I think it's our way of exploring the patient's perspective, right? We always start any goals of care conversation with exploring what the patient understands about their condition. And so what's your understanding of what you hope to get out of using this ivermectin? And then I think that can lead to a really thoughtful, deeper conversation about benefits and potential pitfalls of the treatment, right? Like, what are you hoping the ivermectin will accomplish, and how will you know that it's doing what you hope it will do? If I prescribe this, how are we going to monitor for side effects? And I may not, ultimately feel comfortable prescribing it, and we can continue the conversation from there. But I think starting off from a place of humility and an interest in learning more about the therapy will always benefit you as the clinician. I think also they're coming to you with this because at least to some degree, they trust you to not be judgmental about it. I doubt they would necessarily come to you to prescribe this if they didn't think you were someone they could trust and be at least open-minded to hearing their perspective. So I want to show them that, in fact, I am open-minded and to gain their trust even further.
Okay, you talk to her. She says, I've done PubMed searches on this. I recognize that there are no human randomized control studies, but here's a paper from 2022 showing, anti-tumor activity in mice and cell cultures. And here's another paper in breast cancer that shows activity when combined with chemotherapy. So there's actual papers out there, but there's no high level evidence. And it's more theoretical in your interpretation. What the heck do you do now? Okay, here's ivermectin, knock yourself out.
If I'm going to wear my ethics hat here for a minute, I would say that it is one thing to say, like, I will partner with you while you pursue this therapy, right? I can't control what you do, but what we can control is what we do. And so if we think if someone is asking for a therapy that we think not only will it not provide benefit, but it has a higher likelihood of harm, we're under no obligation to provide that. And I've had to set that limit with patients before. It's like, no, I want this one very specific thing. And it's like, I'm so sorry. I wish this is something I could do for you. This simply doesn't have enough evidence for me to feel comfortable prescribing that for you. Like, I would like to talk to you about other things that I think will provide benefit if you're open to that. And so I'm always, it's never abandonment. It's never, that's a dumb thing, get out of my office. It's always, I want to give you the best care possible. It may not be this thing that you're asking for. And I understand that you may go elsewhere to pursue that, and you are welcome to do that. But let's talk about what I can do for you here today.
Yeah.
I think also that's where exploring the patient perspective on the front end is most useful, because if they are hoping that, for example, the ivermectin will alleviate some cancer-related pain they have that's been poorly controlled, I'm hypothesizing. Wow, we have so many other tools that have a large evidence base to support their use for alleviating cancer-related pain. May I share with you what some of those tools are and what they can look like and how they might potentially benefit you? And so again, I would rather open the conversation to more ideas and discussion rather than, close the conversation down by dismissing their concerns. So I think that's why all that work up front is essential.
I was going to say too, just like sometimes that early conversation, like Laura, you were saying, is so important because you also figure out that what they were demanding when they first brought up this treatment is actually not really at the root of what they're looking for. And so often, like if you have a good relationship with them and you can understand what that root is, there's so many other ways to come at it. And they're willing to back away. Like, I think it's rare actually that I get that, are you going to do it for me? And if you won't, I'm going to walk away. Way more often it's, like, oh, you don't think it's a good idea? Why not? And what else can we do? And then we end up in a totally different place.
And I'd also say that what I loved about your article is a lot of, like, all the evidence that I just pointed, like this really marginal, like this is not level of evidence that we would use to prescribe drugs. But I haven't yet actually talked about risk, right? Or what's the downside of it? Whether it be health risks, financial risks, all of these other potential risks. And your article dives into that. And I think there's a really good analogy when we talk about like feeding tubes in people with advanced dementia. You can talk all you want about the lack of benefit, but if you don't talk about risk, it's not going to go. Like, what are you most worried about? Is honestly, it's not the lack of benefit. It's like a third of people need chemical or physical restraints to keep that in. They're not going to be moved to the dining room. They may have increased risk for pressure ulcers. All of these risks I'm gonna put feeding tubes in advanced dementia as a PULET.
PULET. That's a fruit.
A PULET is a fruit. It is also a PULET. Yeah. Fine.
Delicious.
It has
fruit.
a nut
Stone
in the middle.
Fruit.
So,
and I'll throw a couple other. Wait, are you finished?
Yeah, I would just want to. Any other thoughts about how you incorporate risk as part of this discussion?
Yeah. Right.
I think for me, it always goes back to what are your hopes? What are you hoping for from this PULET, from this, potentially unsafe low evidence therapy? I don't use the, acronym PULET with my patient necessarily, but I'm thinking it in my mind. What are you hoping will be the result of trying this therapy? Like, what are you hoping you will achieve from placing a Daboff tube and artificially feeding grandma? And how will we know if it's helping or not? And I want to share with you some of the things I'm worried about. And if your hope is for grandma to get stronger, to be more interactive with family members, I'm actually really worried that placing this Daboff tube will actually get us farther away from that goal, not closer to it. And here's why. And so for me, whenever I'm incorporating risk, it's in the context of what they've shared with me are their values and priorities and hopes for the result of that intervention. So I'm a broken record, but it always goes back to, why they're even thinking about this in the first place and what they hope to get out of it.
The only thing I would add is that if you find yourself arguing over studies and methodology, right? You're doing it wrong. If you are trying,
sure.
right, if you are arguing about the argon light therapy, if you're arguing about like the details of the intrathecal stents, like you are missing the bigger picture. Because I think especially in these high intensity situations, these are emotional statements, right? This is emotional decision making. And, bringing cognitive argument to that, I think you'll always be at a disadvantage.
But there's a role, right, for the cognitive part?
Absolutely, there is. But I think that that's honestly the attending to that emotion, that aligning with the patient, that validating their approach, or validating the hopes that underlie this request is 90% of the conversation. And like Jill said, most of the time, then that cognitive argument kind of melts away. Oh, you don't think this is a great idea? What else can we do? Mm-hmm. And so again, at the time that I have found myself like Googling things and pointing up at this, look at the study design, mm-hmm. This is flawed. Like, no, I'm doing it wrong.
Mm-hmm. I want to bring a few other ideas into this discussion. The first is prospect theory. There's this, we did a podcast on nudges, mm-hmm. and, Kahneman and Tversky. There are many names for this. Cognitive biases. And this idea of loss aversion is that people's decision-making changes when facing potential losses, and they're often willing to tolerate a greater risk because of the threat of loss. And this is one of the reasons why it's so emotionally amped up, because we're talking about death here. Arguably the greatest loss that one can face, either in themselves or their loved one. So that's one thought. And another related thought is, there's this strong sort of principle in America of allowing patients to try things that are potentially unsafe and risky, and that doesn't just extend to medical therapies. The major rock climbing magazine has an obituary section, So why should it be different at the end of life? In fact, the Right to Try Act, signed into law in 2018, allows patients with life-threatening illness to access investigational drugs that have completed phase 1 testing but are not yet FDA approved. So in some sense, I guess what I would just kind of want to point out here is like aligning with patients that it's, we understand not just the emotions that are driving this, but also that sort of calculus that they're weighing in their mind and why it might be different closer to the end of life. And that in many facets of American life, we allow people to make incredibly risky decisions. Yeah. Any thoughts about those reflections?
I would just say that, this article isn't about what are patients allowed to do, right? It is how do we react in the face of it? Again, how can we approach patients with this humble inquiry that isn't dismissive, right? Especially when we say, some 80% of patients with cancer will engage in some form of complementary alternative medicine, kind of broadly say, dismissing all of it, you're going to alienate 80% of your patients. And how can you continue to partner with the person who is making decisions that you may disagree with, while also still, right, setting those boundaries. You're allowed to do what you're going to do. You can't force me to support or materially, be complicit in an intervention that I think is going to harm me, that violates my professional ethic.
So setting that boundary that you're not going to prescribe the drug because you're worried about the risks and you're seeing no benefit and you're understanding how important this is to them, but you're also setting a potential limit.
Yeah, absolutely. And not just prescribing. There have been cases where people have said, hey, in order so I can pursue this therapy, will you order this battery of tests? Yeah. Right? Will you order these different things? And saying, it's like, well, no, this doesn't make a lot of sense. I recommend you go back to the provider who's doing this to get that testing if that's what you need. But I can't endorse this and I'm worried about your safety. And so this is why. So that same kind of idea that we shouldn't be supporting therapies that we think are potentially harmful.
Well, and I think to jump off that, Adam, one thing I hear a lot from my seriously ill or more often terminally ill patients for whom we don't have any further disease-directed treatments that are likely to benefit them is that leave no stone unturned philosophy. I think that is also very American, right? Like we have to try everything possible, no matter what, even if there's almost no chance of it being beneficial. We've got to just try it. And I think sometimes I feel that it's my duty, given my professional background and expertise, to share that there actually are trade-offs to leave no stone unturned, right? And those trade-offs are real, right? We might be sacrificed. If you have to go to an infusion center for 3 hours, 3 days a week, that's time you're not spending with your family and friends making meaningful memories. So I think, I agree, Alex, that's sort of a philosophy that a lot of people in Western culture hold, but I also think sometimes we forget the trade-offs and the other things that we're losing when we're making a decision to pursue some of these pullets. So
I love that. That's honestly my biggest pet peeve. Often, like I see so many times we talk about the lack of benefit, but we don't talk about the trade-off. Like if somebody is dying and there's a 1 in a million chance something's going to work, like why not? But
lots of
if there's a real risk, like worsening delirium, seizures, hepatic failure, like then all of a sudden, now we're talking about trade-offs. And I think people understand that much better than this idea, oh, we're just not going to try it because we don't think it's going to work.
Right. And ivermectin, just so we can sort of articulate some of the harms, right? What has it been associated with? Confusion, ataxia, seizures, hypotension.
Yeah, and you worry about, especially when you're giving with other medications, liver issues. It's general, and I bring it up because it's generally a fairly well-tolerated drug.
Right.
But there are risks. Again, if you PubMed it, you will see articles about anti-tumor activity, but there is really no high-quality evidence.
Right.
So
if it's not going to help you, why put yourself at risk of experiencing these potential harms? Why would we do that? Yeah.
So I did try to ramp it up, pick the hardest drug I could. So I appreciate it. I wonder if each of you, as you think about this, any particular pearls, kind of like if you had a magic wand that you could like think about how providers address, I was going to say pluots again, not pluots, pullets with their patients, what would you use that on? Jill, I'm going to turn to you.
I'm going to steal Laura's line and just say, I think it's all about the upfront communication. So just sinking into the conversation when you feel your heart rate start to rise, when someone's bringing you a request, just settle in your body. Remember, you're just here to connect with the person and have a thoughtful, authentic conversation. And it will really get you where you need to go, I think.
Laura, another one?
I would say, try very thoughtfully to dig into the underlying emotion and fear driving the request. And if you can get there, you can often provide other opportunities to help the patient that are much safer and likely to be much more beneficial.
And Adam?
I would say, Laura mentioned before, humble inquiry, and I would say avoid the opposite, right, which is false certainty. And so if you've heard that ivermectin in cancer is not a great idea, make sure that you have done that. Are you aware that there are PubMed studies, right? Because I'll bet you they are. And if you are speaking with false certainty that they catch, then you've lost any kind of authority or opportunity to partner.
I love that. And I think I'm bringing up ivermectin. You could pull up probably any drug, herb, anything out there. There's going to be a PubMed study out there. And it's going to say something that you probably strongly disagree with. Like you can find one article. I think that's a great example because there's a lot of bad medicine out there. I don't know. I just try to transition to the song.
Good segue.
It was a poor transition.
Your love is like bad medicine. Bad medicine is what I need. Shake it up just like bad medicine. Ain't no doctor that can cure my disease.
Okay, so many Bon Jovi songs. You get Living on a Prayer, another good one for this episode. Yeah. Adam, Laura, Jill, thanks for joining us on this podcast. That was awesome.
Thank you.
Thanks so much.
That was really fun.
And thank you to all our listeners for your continued support. And we'd like to send a special thank you to all of the donors who've donated more than $250, including
Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulski, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordofsky, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Bragman, Elizabeth Chung, and Paul Amatelli.
Thank you very much for your support.